So, like I was saying, we're going to be having a very interesting conversation today, and it's about, can you see this? Eliminating unhealthy interprofessional rivalry in healthcare. So, I don't know, has any one of us experienced rivalry in the healthcare system? Where you work, the hospital, the medical center, the clinic, have you experienced unhealthy rivalry in any way? Would you like to share your experience? You don't have to call names, but you can just share. Give us a tip. You seem like someone that's experienced something. Okay. Anybody quickly before we continue. So it means that our healthcare system is working perfectly. Eh? We are all collaborating, we all have a good rapport, nobody is fighting anybody. That's what it means. Susie, share for us now. Okay, good. So whatever the case may be, hello, are you with us? So if we decide to start recounting experiences, you have one or two things to say, certainly, most definitely. Okay, and while I continue this presentation, you'll be getting, because the truth of the matter is that some of us are in systems where we don't, we've so much been engrossed in what is wrong that we don't even know. So that thing that is wrong becomes a new normal. So even when you are being abused by a senior colleague or you are being abused by another professional is encroaching into your rights, you don't know, because after all, that's how it is. You know, some of you have worked in systems where they will tell you, this thing you are saying, it's been like this since 1960. It's now you, corporation that wants to come and change it, you know, or when you were an intern. It's been like this all the while. So who are you to come and make that difference, right? But we are going to be seeing more about that as we continue with this conversation. So this topic is eliminating unhealthy interprofessional rivalry, the secrets to MDT success in the healthcare system. And from my little big experience, I can say I have a lot to say. Definitely a lot to say. And what I'm about to share with us here is going to make the difference in your practice, wherever you find yourself. It's going to make all the difference in your practice. So what is unhealthy interprofessional rivalry? Or let me say, let's talk about the impact. You can have negative impact on the effectiveness of the MDT, the multidisciplinary system. And I'll be sharing strategies to eliminate this rivalry that I brought up today. Now, these are typical examples for us to set the tone of the conversation. Okay? So if you are in the group chat, you can just help me check the link. Maybe click on the link and see if my audio is coming out well and give me feedback. So if we're going to discuss this, we can't do that without giving typical examples. And that's what I decided to do first. Before even coming to definitions, what are the things that you are probably experiencing right now or you are going to experience in future that you need to understand about this, where this will come in? You know? Now, number one, I don't know if you've noticed some aggressive nurses and matrons. I'm a physiotherapist. I worked in the ICU for a while where I did my internship. And I had some really nasty experiences with some nurses, some matrons, you know, very nasty. And at the end of the day, I found out I wasn't the only one complaining. I had friends who were doctors, you know, that didn't even like going there anymore because this is what's happening. Very aggressive. Oh, what are you doing? Why are you coming by this time? I need to feed the patient. This is the time I'm meant to come, but you need to feed the patient because you want to go early or something. Something just came up for you and you want to change the time. You know? And then sometimes you begin to realize, or if you care enough, you realize why they are doing that. You realize why some people are the way they are. That's why I'm doing this. That's why I'm presenting this topic. Right? Now, number two, I'm a physiotherapist. I'll be a hypocrite if I don't slam my own self. You know, if I talk about other professions and I don't talk about where we are getting it wrong, I'll be a very a big fat hypocrite, right? And I've equally noticed that some physiotherapists who are unnecessarily aggressive towards medical professionals, I mean medical doctors particularly. So it's like the chaos, the fight, the unseen, invisible war that is going on. And I see younger ones who are carrying what they don't know on their heads. What you have no part in, what doesn't really concern you so much, you now carry the bad aspect of it and you're running with it, right? So there are some physios who are also aggressive towards doctors or other medical professionals. And some maybe generally, not just physios, there may be incompetence on your path. You know, that you're not able to identify that, okay, this is not what the patient needs at this point. This patient doesn't need to be on this, he needs to be on this. This patient, you know, is not my client. The patient should be referred. So if I, as a physiotherapist, I'm not able to identify certain red flags, certain points that this patient is definitely not fit for physio, and refer to either the initial referring team or to the specific team that is meant to be seeing that patient, then I'm getting it wrong. Then I'm not playing the game well. I'm not working effectively in the team, right? And doctors delaying referrals. We see this a lot, particularly as a physiotherapist. There are some patients who are candidates for physio, but they don't get referred early. You know, they get delayed till maybe complications start setting in, and then they refer. And sometimes the way it's being communicated, the patient is now expecting us to do magic. And it's a lot of problems, a lot of drag for us, right? Now, sending consults inappropriately. I'm giving typical examples here. It was one of the major challenges I faced. So sometimes you see a medical doctor write consult and send to physiotherapy and tell us what to do. You know, put patient on infrared, do this, do that. You know, that is very condescending. I mean, it's quite insulting. And some people who are not so gentle to manage it, they can flare up. It can turn into an internal crisis. So it's very, very important that we learn how to communicate with ourselves so as not to overstep boundaries. I've also seen situations where a doctor gives the patient advice and says, oh, do this exercise, instead of referring to physiotherapy. I had a conversation with a friend and she told me it's because they don't really trust us. You know, they don't really, whatever we know, they know it. You know, and I don't blame her. It's the level, the extent of our ignorance. Because professionalism is not about you knowing how to do everything. Obviously, you can't. It's about knowing where your own knowledge stops and where that of the next person begins. Knowing when to refer is professionalism. Okay? So I should be able to spot red flags and say, no, this kind of swelling is not me. Go and see your cardio. I should know when to say this kind of pain. I think it's looking like, you know, this is looking like it's going to be an oncology case. Or go to your referring doctor and talk to him again. Take this consent to him. Okay? So in this case, there are ways to refer without insulting. You know, there are ways to send referral notes without insulting. You don't tell a professional what he's meant to do for the patient. It's okay to put a call through even. Okay, go ahead. So when it happens again, just scroll down, turn the off and on. So now, the next one is commandeering. There's a way you can approach a medical professional and communicate your intention, communicate your agenda without sounding like you are bossing them around. And this is connected to this first one. This is one of the reasons I discovered personally that a lot of nurses and matrons are aggressive. You know, because they're doing a lot of work. I mean, these people are doing so much work. So much work. They are drained, they are tired. And then you come and do this. And you're like, it seems as if it's coming out as a command. oh, this patient is this patient is, So you have to be careful. I have to be careful the way I communicate with other members of the team, so as not to frustrate them. Trying to do the work of, I've already talked about that one. Subpedaling other professionals in policy making channels, right? We will not act like we don't know what's going on. I try to stay as current as I can. I try to know what's happening in the news. I try to follow what's happening, NMA, Joesu, whatever, right? Now, as much as I do not foster such strife, it basically doesn't concern me so much, really. Because I do not believe that because this person is earning this salary, I should be earning this salary. What the hell does that mean? There are many other things that can bring you the kind of money that you are looking for than to be pursuing government salary up and down. They will increase, they will not increase. Those things that, to me, it's not really what matters. So at the same time, in the same vein, it does not make so much sense that somebody is going to be trying to shortchange another person in policy making. It's not a good thing. Because I believe we should be there for ourselves. For me, I personally want the doctor to earn more. Much, much, much higher. I would want the nurses to earn much, much, much higher. I would want myself to earn much, much, much higher. For everybody to be happy, sane, sound, safe. So it's not about, oh, we should be the Oga, we should be the... No, it's not. Now let's continue. Let's move. One of the reasons there's always this rivalry, I'll continue with more examples, is because we do not know where each one of us should come in. And most of the time you find out that our training is deficient. I'm going to be saying some things that may sound very corrosive here, but receive it in good faith, because getting these things right begins with us. I have to be honest with myself to say, this is where I know that we are not doing it right as a profession, as a physiotherapist. Yes. And even when I see my senior colleagues, I don't try to mince words. But if I decide I'm going to even drop the profession, nothing is going to happen. So I don't try to mince words. I can't be in anything that is not working. And that's what I want us to also imbibe as professionals. We need to come to that point where we actually know where the other person comes in. Where we are, and see, sometimes you can't get all that information through one class. You can't even get it, maybe if you do a master's degree or you go and do PhD, sometimes you can't get that information. Sometimes the most important information is the one you will get by communicating with yourselves. By saying, oh, this patient I was seeing, she's taking Tegretol and she's taking this. What do you think can be the drug-to-drug interaction? That she has been having, persistent high blood pressure, the blood pressure is not, this is not working, and she's having some kind of, gastrointestinal problems. I talked to my doctor friend, I talked to the pharmacist. What do you think about this? From their ideas, from what they are putting in, you'll find out you can actually get a lot of information about your patient. I'm saying this from personal experience. When a patient who was having very, very severe complications, that the solution came from my friend, the team of pharmacists. They were able to identify, oh, this drug that this patient has been on, this drug is reacting with this, it's cancelling the effect of this one. So we don't think this should be. Let's get back to the doctor. That communication saved the patient a lot of time and money and stress. A simple conversation. Now, these are the things that can help us. A few of the things that can help us. The pharmacists want us to know that their role is beyond drug dispensing. Am I right? Am I saying your mind? Any pharmacist in the house? Okay, good, beautiful. So the pharmacist, I used to think that pharmacy was easy apart from biochemistry. That course show me shege for university. I used to think it was just, okay, after the right to the medication, I started learning so much from a conversation I had with my friend. Then we are going from the same axis, the same bus. So we'll have conversation, we'll be disturbing everybody in the bus from where the junction to National Hospital. So we'll be talking about drug interaction. He's teaching me so many things. I was like, this guy is too good. And We bring out some of our patients that we know and we discuss the drugs that they are on. I did pharmacology in school. It wasn't a course I enjoyed. I was like, oh, thank God they are pharmacists, thank God they are medical doctors, let them handle this one. But at the end of the day, I realized I can't do without it. Now, talk about drug administration, policy making, research, production, compounding, so many things that they come in. I did not know until I had that conversation. I would have just assumed, and assumption is a killer of relationships. It's a destroyer of benefits. So now, physiotherapists want you to know that we do way beyond massage and infrared. I've had cases where doctors refer patients for infrared and massage. And at that point, I flare up easily. I get angry. I'm like, we can't receive this. Send this back. We are not receiving me. It got to a point they knew. Once it comes, then they collect it and put it somewhere. She's okay, we'll get angry. Me as an intern. I'm like, if you want massage and infrared, or if you want massage, go to a spa. It's that easy. Just go to a spa. You come, we assess, we make our own working diagnosis, and we treat or refer if it is not really our patient. So we have to come to that point where we are able to trust. There was something that happened in the national hospital. We had grand rounds. And, I brought up this issue. I brought up the issue about doctors referring and telling us what to do. And the consultant said, because I was trying to say, you shouldn't tell us how to do it. You shouldn't tell us what to do. Tell us, just note your findings and everything that you think will help us in making our own, findings and treating the patient. But don't write what we are meant to do. Physiotherapy is an autonomous profession. May not have achieved first contact status in this country, but that does not mean that it is subjected to any other profession. But the consultant got up. One consultant got up and, he fled up. He got angry with me. Why would I be making that kind of comment? He was trying to point at the fact that we are not independent. So they have to prescribe our treatment too. I wanted to react to him. They didn't give me the mic again. As well. So the nurses want to be respected more and treated better and not bullied or intimidated. Do you who? Consultants, super consultants, consultant pro max, whatever. Do not intimidate. There have been cases of doctors slapping nurses in the ward. I'm not saying some nurses have slapped doctors too. I'm not just saying it's one-sided. But they want, from my conversation with them, they want to be respected. They want to feel acknowledged. They want you to come around and say, oh, thank you very much. You're doing well. This patient is doing well. You're doing a great job. Sometimes those little conversations make all the difference. I do it a lot. So I go to the ward and I see my patients and I come out, I have a chat with the nurses and I laugh with them. So it came to a point, I couldn't relate with what people were saying. So people will go to the ward, they will complain, this nurse, I don't like seeing this nurse. And they're like, well, you are everybody's paddy. How do you do it? Communication, acknowledgement, gratitude. So they want to be treated well. They want you to advocate for them too. We all want ourselves to advocate for us. We all want the other person to advocate for us. It came to a point, people thought I was a nurse. Because every time you hear me talking, I'll barely talk about physiotherapy. It's nothing this, nothing that. Because
Like I was saying, is it back? Okay, things went off. So like I was saying, when the chips are down, all we have is ourselves. There may be times where in your clinic, in your facility, you will be down with one thing or the other. At that point, the only person that can rescue you is the person you've been trying to undertalk or subvert or intimidate or bully. It's the only person who can help you. We've had multiple instances, a doctor coming into our department and pleading, my neck is hurting me. I mean, I don't know what happened, but for the past 3 days, I've been down. This thing's really giving me concern. I don't want to take medication. First time I heard it, I was like, okay, wow. And they came to physio. We don't say, oh no, go and get this one, go and do NHI, go and do this, go and do this one. No. Sometimes we try to make the thing as easy as possible and attend to them. Why? All we have is ourselves when the chips are down. I've had the experience. There was when I had the ENT issues. It bothered me. I couldn't sleep at night. I thought I was going to die. When I came in and they said, okay, you're an intern, you're a staff here, and let's make the thing faster for you. Follow this side, they're just cutting corners. And I saw the doctor. They gave me certain medications, did the ear test for me, did everything, recommended this, recommended that. In a few days, I got fine. I mean, that did something to me. Where I'm currently working, at the point I felt ill. Everything that was done was just so fast. It was just so fast. Just because, oh, you're a physiotherapist. The doctor just carried me by the hand. Oh, Chijoke, my friend, come, let's go. I went there, I saw a crowd. I said, oh God, I'm going to probably fall here and just faint. He came with his bag. He said, oh, Chijoke, are you still here? He picked me. Come, let's enter my office. I was the first person he attended to while he was coming. Why? All we have is ourselves. Funnily, he himself was my patient. There was a time he had one hand injury. So I was the one that treated him when he came. So you see how these things revolve around us. Right? Number 2, improve patient care, especially for patients whose cases require the FPT. Cases like diabetes mellitus, type 2 diabetes mellitus. Cases like hypertension, stroke, cancer, arthritis, back pain. These are issues that we need to reach consensus on. Now we need to understand that it's not just my case, it's not just my patient. So if I am a doctor, I'm a medical doctor, and a patient comes to me with knee osteoarthritis, and the pain is much that it's preventing their it's disturbing their daily life. And I just give them, oh, take Atrotech, take this one, and you'll be fine. Come back in 6 weeks. I have to be able to tell myself that no, this is not the right thing that I did. Right? So in cases like this, you should be able to refer appropriately. In your systems where you work, there are, antenatal programs for pregnant women. That antenatal program, the midwife should be there. The midwife should be attending to them. The nurses should be there. The O&G should be there, to give them lectures and all that. Very, very importantly, the physiotherapy should be part of the team. Very, very, but in most settings it's not like that, because sometimes people don't really know. The professionals involved do not even know that, there are things we should be doing for these people, for this population. So it's important for improved patient care. At the end of the day, the patient is going to get the best treatment. They will stop coming to disturb us. And you will be happier that, okay, I worked with a team and we managed this patient, and now this patient was, in a disabling condition before, was in a vegetative state before, and now the patient is walking to my clinic to come and say, hi, I'm coming from physio, but I decided to come and see you. You will be happier that your patient is doing well. Is that not? Now, the next thing is increased efficiency. It makes work faster and easier for us. You don't have to bear all the load. You don't have to bear all the body. There are times you just need to refer. Oh, I don't really know, but let me call my friend who's a pharmacist. Let me ask him some questions. Sometimes it's that easy. Let me call my friend who's a physio, let me put a phone call through, and I'll put something in writing for you to take to him. It's that easy. Now, the next one is better communication and collaboration, enhanced professional development. Why? We get to learn more from. I was telling you the story of my friend Timothy. We did internship together, the pharmacist guy. You know, I was able to learn a lot from him about drug-drug interactions. I was able to learn how the medication the patient was taking was affecting even his GIT and causing him constipation. It was really affecting our therapy until they changed the medication, the BP normalized, the man was able to pass phases. We came, we did the physio, it was easy, the tone improved, everything just improved. Just like that. Now, what is unhealthy competition, unhealthy rivalry? Unhealthy competition and strife between the healthcare professionals from different disciplines include but are not limited to hatred, resentment, unjustified aggression, envy, and being a loggerhead. I know we all understand this one. So let's try it. Common causes of unhealthy rivalry and entity dysfunction in healthcare systems. These are the common causes that we need to note. We need to, take note of. Number one is lack of communication and collaboration. When one person in the team feels like he can do it all for himself, but that he knows everything, so he doesn't need to refer, he doesn't need to call and ask, he doesn't need to verify anything. So he's just going to be there. Now, this is not ruling out the fact, I'm going to come to the doctors, it's not ruling out the fact that the doctor is the head of the MD team. Of the MDT. The medical doctor in charge of the patient is the head of the multidisciplinary team. He's the leader of the team, but he's not the number one. The number one is the patient. Now, what it means is, effective leadership is not your ability to throw people around or to boss people around. Effective leadership is your ability to coordinate a team. Effective leadership is service. Effective leadership is your ability to understand that the people that you are leading need your help. They need to be taken care of. They need to be communicated with. They need to be spoken to with respect, and they deserve that respect and courtesy. That's effective leadership. Now, when you're able to do that, you will definitely see the effect. Now, let's look at the next one. Pride. It's pride that will make a physiotherapist not refer when he should, or not call for help when he should. You're seeing a patient with palpitations, and you probably don't even know what to do at that instant. You don't know when to refer. You don't know when to call. Okay, I noticed my patient's leg has been swelling. We've tried elevation, we've tried this. What do you think I should do? Write a note, send him out, check him out. It's that simple. Even from the electronic whatever, we should be able to foster that collaboration and communication for the patient, for the best service of your patient. So, pride will not let you even ask for help where you should. There are some places in the world, and even in Nigeria, where physiotherapists do suction. That thing scares the living daylight out of me. I put in the suction to reserve somebody's the patient's they are gagging. A patient that is, the distance is very low, and you are putting. I'm like, what if the patient goes from here? It scares me. So luckily for me, when I came to National Hospital, it was done by the nurses. It's the nurses and the matrons that do the suction. So I didn't have to worry about it. I was even thanking God. So if any of them mistakenly ask me one day, physio, come and say, I'll say, I don't know. Sorry, this one it did not enter it was in my curriculum, but we did the theory. I did not suction anybody, so just handle that one. I'm willing to learn. I did this a couple of times. I had a matron that, people used to fear the matron. When I came, within the first week it was tough for me. By the second week, when I come, all you hear is, my son, are you here? My son. How did everything change so fast? I will come around and I'm looking at the ECG and all those machines, the patient's monitor. And I'm looking at it and I'll call her. The what is it called? Artificial ventilator, the mechanical ventilator. And I'll call the matron, ma, look at this, I don't know, I'm seeing so many things here, I don't understand this one, I don't understand. She said, okay, I'll teach you. With my colleague, we'll pause, and she starts teaching us and explaining some things to us. I'm like, wow. By the time I'm done, she will now crack a joke. She will now be like, oh, you should pay me some part of your salary, because this one I'm teaching you is extra job. People are disturbing me. You pay me for this, and we'll all laugh about it. So next time we come, you'll be hearing, my son, my daughter, my children, are you here? The tone of the conversation has changed from, this physios again. You will not allow my patient to rest. You again, you did not come on time, you did not do this one. It changed. Why? Humility. Now, superiority complex. Some people feel they are more superior than the rest. Now, let's establish the fact. As a physiotherapist, I'm not more important than or superior than the pharmacist or the med lab scientist. Sometimes because we don't know what they do, because we don't know the amount of work they put in, because we don't know how much they prepare and study and all that, we feel like, no, we are doing more. I went to school 7 years, I went to school 6 years, I went to school 9 years, I did this, I did that. So there's no way, right? But if you realize how much impact they are making and how much the system will crash if those people are not around, you will start to honor and respect them. True. So that superiority complex is not necessary. Let's eliminate it. Let's learn to acknowledge other people where they come in. Now, the next one is inferiority complex. There are some people too that even to have simple conversation with the next person, with the other professional, they are so afraid. Because they think they don't know enough, or they think they are lower. Oh, I'm not a doctor, so, it's not meant to be like that. You should be able to walk up to a fellow professional and discuss like a learned fellow. Look at what I noticed about my patient. What do you think? Even if you don't know, it's not a crime. It's not a must you know everything. The person you even tell you may not know it too. So, why not? So now, the next one, grudges and preconceived notions and past experiences. So because a doctor did something that annoyed you in the past, you are not using that to preconceive. You are not using that to judge every doctor you meet. Because you've had a sad experience with a pharmacist or a nurse, you are not using that to judge every nurse that you meet in the future. Okay? Now the next one, power imbalances. This is very, very important. But I'll skip this. Sheer ignorance is also another one. If you do not know when you should call for help, you can't call for help. If you don't know when you should invite the other person, you can't do it. So now, these are the negative impacts of unhealthy rivalry on MDT. Number one, reduced trust. 2, increased errors and adverse events. So now, if I do not know when to call another professional, so let's say if I'm seeing signs in a patient that I'm managing, so you're treating a patient and at the point you notice that the person is you notice that the person is hyperventilating, or that the person is the heart rate is dropping so fast, or something, or chest pain, or headaches, or dizziness, or something. There are some signs that I should be able to notice, and I'm like, okay, calm down first, let's check your BP, let's do this, and let me refer you quickly to go and see your cardio. Okay? So that is very important. And when you do not now do that, you can be managing a patient and the patient has a cardiac arrest. And the patient dies off. Those are the adverse events we are talking about. Inefficiency in the system. So because a stroke patient was not referred early for physiotherapy for their rehabilitation, it's not going to be hard, very, very hard for them to come back to a level of efficiency or a level of independence in the future. So we should know what studies are saying. Studies are saying that women who physiotherapists are involved in the antenatal programs experience less issues during delivery, less risk of perineal tears, less, in fact, it's even safe for the baby because there are some exercises that will even help the child. Prevention of maternal and infantile obesity. Not even infantile. What is it called again? Fetal obesity. So many things. But because we don't know or we don't want to involve, these things are going to come as adverse reactions, adverse effects, adverse events. And we are going to be embracing them as normal. Meanwhile, these things can be prevented. If only we communicated well. Right? Are you with me? I hope you're not tired. You're tired. Okay. Oh, refreshment. Bring the cooler. Okay. Thank you very much. So, lower quality of care and decreased job satisfaction. Now, if we are not working as a team, we'll be carrying so much labor on us, right? And because of that labor, you'll be stressed. If your patients are not being discharged because they are not receiving physiotherapy early, or because the drugs that they are taking is not what they are meant to, it's not rapporting well in their system, you will be stressed because they will remain there. Okay, now fostering a culture of collaboration, bearing in mind that these are the strategies that will help us to eliminate this rivalry. Okay, we should foster a culture of collaboration, knowing that no professional has monopoly over any patient, and the patient is numero uno. The patient is number one. The patient is the boss. The patient is the lead, is the number one. Is the one that we are there for, right? So another one is regular team meetings and joint training sessions. Another one, shared decision making and problem solving, encouraging interdisciplinary learning and skill building. So it's important for us to come around frequently, and that's part of why we are doing presentations here. Our sister, anatomist, right? Yes, she did a very fantastic presentation on obstetrics and gynecology here one of the days, and I loved it. That's why I exchanged contacts. I collected her number, because in future I may need to involve her in something. I may need to go for an outreach somewhere to go and do something for pregnant women, and I'll come along with her, or even for health professionals, and I'll just come along with her, because I know how capable she is, right? So an anatomist may help you appreciate the system more, appreciate the structure more, no matter what you are doing. So now, we need to come around and talk to ourselves about what we do. We need to ask questions. You need to come to pharmacy and say, oh, what's this pharmacy? Like, tell me more about pharmacy. Tell me more about where you come in. Tell me more about, how you function as a pharmacist. That's very important. Now, decision making. We should be able to come together and say, this patient that we are having, even as house officers, house officers, corps members, in your respective clinics, start making friends with other professionals, and you see how much difference it will make for you. The good thing itself that you don't know is, in the next 3, 4, 5, 6, 7, 8 years, some of your friends will be consultants, some of your friends will be in very high places, some of them will be working with governors and presidents. You don't know this part now. But because of the rapport that you have with them, when the time comes, they're going to be like, oh, because you are the one that they know that can do it. Oh, I'm seeing the president of which country now? President of Rwanda. I beg you. So I'm seeing the president of Rwanda, and he needs this, are you open to flying? We'll fly you. Me, I'm open, I'm very open to flying, just in case. So that's how it is. You never can tell. It may be the person that you bully today or you oppress today that will be your ticket tomorrow. It's life. It's not entitlement. It's just life. Now, we should be able to hold those conversations and say, this patient, what can we do? I have a patient that is doing this and doing that. I have a patient that they have been complaining of neck pain and this. Do you think physio can help? Do you think at this phase, do you think we should introduce this? At what point should we refer to you? Sometimes just ask. Dialogue. Now, recognizing and rewarding teamwork. Team-based performance measures and incentives. This one, I'll skip this. Celebrating team success and achievements, encouraging peer recognition and mentoring. Now, and this should be interdisciplinary across professions. You can't have as a doctor, you can have a mentor, a professional mentor who is a physiotherapist or a pharmacist. It will even help you stay above your peers. As a physiotherapist, you can have friends, mentors who are medical doctors. I have a lot of them. That today, if some of them, I can call them and say, oh sir, I want to refer a patient to you. Are you in the country or are you in Abuja? That's how relationships work. Now, providing equal opportunities for professional growth, access to professional development activities, encouraging cross-disciplinary learning, and this one I've already said it. So, equal participation in leadership and decision making, encouraging open communication, regular team meetings. I think this repeated. So, addressing conflicts. This is another thing that we need to learn: how to manage and address conflict resolution. In organizations now, it's one of the top skills that is required. Conflict, particularly in Nigeria. Why? Everybody's dealing with stress that you don't know about. People are dealing with different things. Some people, their frustration is because they went to buy fuel and they told them the price has increased, or because they bought black market. They will carry that aggression and enter war. Next thing they're fighting with you, and you think they're fighting because they just want to fight with you, or because you're a physiotherapist and you're a doctor. They are going through some pains. They don't have money, their salary is small, Sapa is dealing with them, and they are carrying the whole thing and pouring it on you. So you have to be able to resolve conflicts efficiently. You have to be able to dialogue. You have to be able to, sometimes, even when you are not the person at fault, you have to be able to just say, okay, let everything die, okay, sorry. You know, so conflict resolution, negotiation, mediation. You should be the middleman. You should be able to stand in the gap and say, okay, this issue between you and the pharmacist, I think this is where we can come in. I think this is what we can do. Let's everybody come together. Or you tell yourself sorry, hug yourself. Okay, so now encouraging self-reflection and empathy. Then next, promoting a culture of trust, encouraging continuous improvement generally, because it's when you improve yourself that you get to know, when you keep learning that you get to even know where others come in. So, this is a case study, but instead of sharing this case study, this is just to prove the effectiveness. This was in Lagos University Hospital that this study was conducted, just to prove the effectiveness of interdisciplinary team management in breast cancer treatment. Now, instead of sharing this study, I'll share my own personal experience. Right? It's the last thing I'll be saying. So we are basically done. Now, this about cancer management. When I was in National Hospital, we had a very wonderful oncology unit. So that one of those grand rounds, they had presentations about oncology and treatment of oncology patients and stuff like that, reconstructive breast cancer surgeries and all that. It was Dr. Shagaya, I can remember Dr. Shagaya that took that session, and I was so impressed. I was really, really, really impressed. Now, at some point, I had to ask the question. Now, when do you refer for physio? Because we started getting a lot of referrals from oncology. Because they began to realize, I don't know how, but somehow the information came that, okay, physiotherapy should be involved in this, one way or the other. Or maybe they've sent patients, maybe pain or something, they sent patients, from oncology. So after a while, they saw improvement from those patients and started sending more. Now I asked the question, at what point do you refer? And she answered me. She said, I'm going to be diplomatic. Like, I'm not going to, I'm going to be sincere. And as much as we should be sending earlier, but it's not common practice to refer earlier. That most times what they do is now when they want to do, there's what she called, I don't know the scan, that they have to raise their arms up and put it on something for them to take an image of I don't know whether it's mammogram, I don't know. So she said it's until they want to do that and the patient's arm can no longer move well, they can't get to full range that they usually refer to physio. But that she knows that the referral should be coming much earlier. So for professionals who know, they are able to deliver more effective care for the patients. And we've had a lot of them. We've had some of them that they come even after the surgery. We see them before the surgery, the reconstructive, minimal invasive surgeries or minimal invasive procedures, that even after the surgery, they still refer them back immediately. And we resume from there, we continue from there. So the patient is happy, I'm happy, doctor is happy, everybody is happy. That's the way it's meant to work. So there are also times where we get to see certain things. You're treating a patient and you're seeing there's a referral pattern that is not consistent with what I should generally manage with my own approach as a physiotherapist. And I know that, no, this is more like peptic ulcer, this is more like gastroesophageal reflux disease, and I should refer to the right expert. Or I should refer to the general practitioner, the GP, the general doctor, and they will do further assessment and take it up from there. So I've had countless experiences working with a team, and it was fantastic. Countless experiences working with the team. The patient is having that stroke, and in the next 2-3 days, once the patient is stabilized, they are sending consults, we are coming immediately. Sometimes I get to meet the doctors frequently, almost every time we are meeting on the same patient. And whenever we meet, it's not just come out, I want to, because some of them can be funny. Oh, hold on, I want to do this. Like, hold on for what? You can't go say please, you can't even say simple excuses. Is it too hard? Some of them will come and they're like, oh, Chijoke, what's up? How's our patient doing? You know, this and that and that. How are we progressing? What are we doing from here? When are they moving to outpatient? Some doctors, before they even discharge patients, they wait for us to come. They wait for us to certify that the patient is due for discharge. And if we don't discharge, they will not discharge. Some of them will, I've met matrons that insisted, patient was due for, they wanted to discharge patient. Matron say, no way. You will not discharge this patient too. That physiotherapy has to come and ensure that they can say that this patient is due for discharge before we discharge. And that's how we're able to work together. When we understand ourselves more, we'll quarrel less, we'll fight less. I remember what I said, when the chips are down, all we have is ourselves. So as much as possible, as much as it depends on you, try what you can to create an enabling environment for any other health professional involved in the MDT. So thank you very much, and I hope we Okay. So we can be going one by one.
For the thumb printing?
Yes. So, yes. Oh, we'll just go upstairs. Okay. Thank you very much. So if you have any questions, you can send the question on the group, and then we'll take it up from there.
Okay. Where do I click?
Yeah?
Where will I click?
End.
I'm not seeing end anyway.
Let me see.
We just need to bring the PC.
Yeah, but
she's faster and she's coming. Okay. Nobody's coming. We're using the
Voila.
Oh, no.
Okay.
So we go there.
Wow.